Yeah, thank you, Alistair, for the invitation to talk to you about performance under pressure in the emergency department and in the pre-hospital and retrieval environment. And for those of you not from the city, welcome to Glasgow. And I would really recommend this delicacy, which is available in Clydebank Shopping Centre, the £4.95 breakfast pizza, which is available from 8:30 in the morning, complete with square sliced sausage, black pudding and a potato scone on a pizza. Luckily, it's only a short ambulance trolley push away from the National Cardiology Centre here in Scotland. So as emergency physicians, we love pressure. We thrive under pressure. Pressure is one of the reasons that we are attracted to our specialty. When the cognitive load increases on us in the resuscitation room, as the department becomes more busy, as the practical procedures that we're undertaking increase in complexity and risk, then we become more focused, more stimulated, more aroused. And our decision-making ability, our communication ability, our ability to lead the team improves until we reach a state of optimal performance flow. But we need to be wary, because if the pressure becomes excessive in terms of cognitive load, we start to perceive the situation as a potential threat, then we can move into a zone of overloaded stress and frazzle, and our performance will start to become compromised. And that's a particular problem for us who are working in the pre-hospital environment as well as the emergency environment. As emergency physicians, you will all understand what we're talking about in terms of pressure, cognitive load. One of my best friends is an anaesthetist, and I was out cycling with him last week, and I asked him about how that applied to anaesthetics. I said, can you give me an example of when the cognitive load on you becomes excessive, when you're trying to make high-stakes decisions that are high risk? And he said, yes, every day at 10:30. So if we want to perform optimally under pressure, we need to stop and think what those pressures actually are and how we can manage that pressure to maintain that state of flow, whether that is the cognitive load, whether it's the personal risk that we're under, whether it's a flash team or the complexity of what we're doing. So since 1908, psychologists have considered the relationship between performance and pressure. And as I say, as the cognitive load increases upon us, all those pressures increase, then our performance is going to reach this optimal state of flow. But it's very easy for us to move in with, when we get excessive pressure or pressure that we are not managing well, into this zone of poor performance. And we can actually get into a zone of choking, where we are completely unable to make a decision, we're unable to speak. There's also a third state of performance with poor performance, when there is insufficient pressure, insufficient arousal and stimulus on us, and that's called disengagement. I like to think about this relationship between performance and pressure as the arc of performance. And emergency physicians in Glasgow have got our own scientific term that we use on a back shift on a Friday night for that zone of frazzle. So what we want to do to optimise performance, patient safety and our own personal well-being is try and maintain that state of flow and avoid that state of overloaded frazzle. So we need to engineer things as well as possible to stay in flow. And if we do end up overloaded, stressed and in frazzle, then we need the tools to bring us back into that zone of flow. The problem is that evolution is making us fight with one hand tied behind our backs. Our actual cognitive capacity for processing information and decision-making is limited. We've got a limited cognitive bandwidth. And that cognitive bandwidth on a busy emergency department shift is easily filled up, leaving no capacity to deal with a complex patient. So man has been on the earth for 200,000 years. And for the first 199,000 years, the cognitive demands in terms of decision-making were really simple, binary decisions to do with survival. If we were attacked by a neighbouring tribe, did we stand and fight or did we run away? And it's only in the past 200 years that things have become more complex and we've been asking more of our cognitive capacity. We've invented electricity, supercomputers, and we've started carrying out heart transplants. So this stimulus in terms of evolution to improve our cognitive function has been really minimal for 99.9% of the time that we've been on Earth. And it's only in the past few hundred years that we've started to ask our brains to compensate with the complexity of modern life. And that simply isn't long enough for us to evolve. So we need to think about how we process information, how we make decisions, and how we respond emotionally to high-pressure situations. So we've got two ways of receiving information and making a decision. There's analytical cognition, and that is a type of decision-making that we use in complex, unfamiliar circumstances. We consciously consider the information coming into us, consciously consider the options, and make a decision on action. So that is essential for those complex situations, but it's also very time-consuming and it uses up a lot of our limited cognitive capacity. In contrast, we've also got automatic or intuitive cognition, and it's based on previous experience. I've been in this situation before, my assessment of it is this, and this is the appropriate action to take. And that's fast, and it uses up minimal amounts of our cognitive ability. We also need to consider the concept of how we respond emotionally to situations of high pressure, and that's known as cognitive appraisal. And just like automatic cognition, that happens very rapidly, and it's based on previous experience. In fact, our prefrontal cortex does this in milliseconds. It sees a situation around us, compares it to what's happened before, and generates an emotional response. Now, what can happen is if we perceive that situation as being a potential threat to us because we've been there before and it's not worked out as well, then before we've got any ability to consciously control that appraisal, then our amygdala is going to send a message to our pituitary and we're going to get a surge of cortisol and adrenaline. That's going to make our hearing impaired, it's going to give us tunnel vision, it's going to make our muscles tense, it's going to give us a tachycardia, and in extreme circumstances, it's actually going to make us want to empty our bowel and our bladder to lighten the load to run away. And that is not an ideal situation to be in when we're looking after a critically ill patient in the resuscitation room. Now, sometimes that will be accurate, that the situation will be a potentially threatening one, but we can also get cognitive distortion where our brain will misinterpret that situation and exaggerate our emotional response to it. So what we need to think about through metacognition, thinking about how we make decisions and handle information and how we respond emotionally to high-pressure situations, is try and engineer how information is presented to us and how we make decisions and respond to high pressure. Now, a lot of what I'm going to talk about here are some of the tools and the techniques that we've developed in the Emergency Medical Retrieval Service in Scotland over the past 15 years. All these blue sky photographs were taken in one day when the sky was blue about 3 years ago. That's actually the reality of aeromedical retrieval in Scotland. So, performance is about flow, and maintaining flow is about managing pressure. So what can we do to actively manage pressure in ourselves, in our teams, and in our organisation? Well, there are 4 things that we can do. Pressure testing, we can train our teams through drilling and through simulation to handle the pressure better. We can control the pressure, minimise the pressure on our team through making as many decisions in the cold light of day and presenting information to our teams in a user-friendly format. As an organisation, we need to think about how we control the pressure in the whole system through leadership, through culture, and through selection of the right people to be able to manage high pressure. And then if we do end up in that situation of overload, stress and frazzle, let's give them the tools and the techniques to decrease that pressure, to regain personal composure and regain situational control. So initially thinking about training. Now, every pre-hospital situation, every emergency department shift, every resus case is unpredictable. And instinctively, we might think that the only way that we can manage that is with demanding analytical cognition. But every complex resuscitation is actually made up of predictable components. So if we can plan those predictable components, we can practice them through deliberate practice and drilling, then we can perfect those, and that allows us to perform those tasks not using analytical cognition but using automatic cognition. So if we repeatedly drill a procedure and if we mentally rehearse it, then we are able to undertake that procedure rapidly, we can do it a lot safer, and we can do it with a minimal amount of cognitive load being used up that frees up the cognitive capacity that we've got for the more nuanced challenges of the resuscitation. If we want our teams to perform well under pressure, we need to let them know why we behave the way that we do, both physiologically and psychologically, when we are under pressure, so that they can recognise that and deal with it. And in particular, in terms of human factors, letting people know about communication. There are many ways that pressure compromises our ability to communicate, both receiving and transmitting information. And that often leads to disharmony in the team or indeed errors in patient management. Concentrating on things like closed-loop communication, use of keywords, and very much thinking about our non-verbal communication and how that is going to be perceived by others. Another thing we can do is stress inoculation. So stress inoculation is a 3-stage process which was developed as cognitive behavioural therapy for patients with anxiety. The first stage is to simulate with a team and put them under a considerable amount of pressure. And then as part of the debrief, get them to talk about what they felt physiologically, what they felt emotionally, i.e. what effect did that excessive pressure have on them. And then the next stage is to give them the tools and the techniques to manage that pressure. And then finally, the third stage is to drill again under pressure and allow them to practice those techniques. Another thing that we need to think about, which I don't think we do particularly well in emergency medicine, is about clarity of competencies. What do we expect people in our team at different grades to be able to do, and to what level? Starting training programmes without that clarity of competence is only going to lead to failure under high pressure. So we can drill and we can train our teams with stress inoculation, with human factors and communications training. But also what we need to think about is giving our teams the right equipment and the cognitive aids to be used effectively in high-pressure, high-stakes situations. Central to that are guidelines. Now, every department has clinical and operational guidelines, but are they really written with the end user in mind? The most junior, the most least competent member of your team at 3 o'clock in the morning in the resuscitation room with a seriously ill patient. Are they written in the right format? Are they in standardised formats? They need to be short, didactic, and they need to be written with that individual in mind. In the Emergency Medical Retrieval Service, we've got 120 of our own service-specific clinical, operational and safety guidelines, and they're all written in a standardised format. The great majority, everything you need to know is on the front page, and they're all stored in an iPhone, iPad app that allows us to access the right guideline almost immediately, even in flight. We also need to think about the highest pressure situations and what can we do to plan for them in advance to reduce the cognitive load on our teams, such as drug doses and equipment doses for anaesthetising a child in the street. When pilots have a problem in the aircraft, like a battery failure or an engine failure, they don't just randomly start poking at the cockpit like doctors do. They get out caption cards, which have been pre-planned and practiced in the simulator. And we should think about those for sudden deteriorations in patients or for equipment failure. So we've got a range of these on our app, and the one on the left is one, for example, that's used for sudden low blood pressure by the Sydney HEM service. So thinking about what do I need to do to keep this patient safe, and then what do I need to do to diagnose what the problem is. Pilots want to keep the aircraft in the air, and then they want to diagnose what the issue is and try and fix it. Calculators as well. How many times have we seen people going completely heads in and been overloaded, trying to work out fluid boluses for a burns patient? So we've got these calculators in our own app. For example, how much oxygen we would need to carry for a prolonged fixed-wing transfer of a ventilated patient. And our own brief aid memoirs for pieces of equipment that are not intuitive to use. And we are never more cognitively or emotionally overloaded than at a multiple casualty major incident. So again, on the app, role-specific, didactic, brief guides as to what your responsibilities and your actions are when you are potentially choked and unable to function. We serve 24 rural hospitals and bring patients to between 6 and 10 large urban hospitals. Each of those facilities has got different clinicians on site, different clinical capabilities, different landing sites. When I'm trying to coordinate a retrieval, that is impossible to memorise and is prone to error. So again, on our app, immediately available, location guides for every different hospital, direct dial numbers to all of the relevant wards in the app. And I think that in emergency medicine, we could be making more use of checklists. 2-person check and response checklists, readiness state checklists for your resuscitation room at the start of the shift, not just to satisfy yourself that all the equipment is there and working, but as a team, that helps to create a flat hierarchy. The WHO surgical checklist demonstrated that gave more junior members of the team a voice, so that later on, if something went wrong, they were much more likely to speak up and get rid of that command gradient. Getting ready for procedures such as emergency anaesthesia. Care bundles. Have I included all the treatments I require for this patient with sepsis? My ventilated patient in the resuscitation room going to CT, are we safe to go? Have we got everything that we need? Have we thought about how this patient might deteriorate and what our actions on are going to be? Ergonomics of equipment. 2-person check and response to check the equipment, but also thinking about how it's laid out. About 4 years ago, 2 of our paramedics, through filming our pre-hospital emergency anaesthetics, decided that our equipment layout was really not ergonomically great. So they designed a bespoke airway bag, which is now commercially available, and we moved to pre-filled syringes for emergency anaesthesia. So this reduced 6 minutes of our on-scene time for emergency anaesthesia and considerably reduced the cognitive load on our paramedics and nurses. And again, we've all been in situations with a deteriorating patient when we've had equipment failure, and how much that can just easily push us into that zone of overloaded frazzle. So again, having action cards to deal safely with an equipment failure and having backup equipment, which is much more of an issue for us in the pre-hospital setting. I think we can underestimate what pressure is put upon us and how performance is compromised by environmental pressures. We take for granted in the emergency department constant interruptions, the phone going, the noise. In the pre-hospital setting, that is a real big issue for us in terms of cold, being wet, wind, vibration in the aircraft, air sickness. And believe me, the Scottish midge can decimate a pre-hospital scene. And even for us, members of our team actually thinking that they're physically unsafe at times, especially flying in bad weather. So we need to invest in the right training and the right equipment to control those environmental pressures and to keep our team safe. And we certainly invest in that in our team in Scotland. So if we've got a limited cognitive capacity and we're starting a shift in the resuscitation room, we want to preserve that cognitive capacity for patient care. Why would we start the shift by bringing in an iPhone and sitting there looking at emails, looking at social media, and have a list of phone calls that you need to make to get your car repaired? inevitably that's going to contribute to cognitive overload if you do end up in a pressured situation. So pilots, when they're landing at a Hearns site, talk about the concept of a sterile cockpit. They know that the cognitive load on them is going to be considerable, the risks are high, and any unnecessary chat is stopped within the aircraft. They don't want that unnecessary cognitive load on them. So we need to think about the concept of the sterile shift, preserving that limited bandwidth for the patient. There are a dozen ways which fatigue can compromise our ability to make judgments, our ability to communicate and work as part of a team. Ideally, minimising the risk of fatigue, very difficult in emergency medicine, but at least giving your teams insight into that and some tools to mitigate the effects of fatigue on performance. So we can train, we can pressure test our teams, we can do what we can in the cold light of day to give them the right cognitive aids and the right equipment. But what if our teams do get into that zone of overloaded pressure or frazzle? So there's a couple of things that we can do. One is controlled or tactical breathing. One of the causes of stress is sympathetic overdrive. So we can try and combat that to an extent by slowing our breathing down to a rate of maybe 8 to 10 breaths per minute and concentrating on the 4 phases of respiration. And those of you that have tried this will actually, it is pretty effective in reducing your heart rate and allowing you to regain control and composure. And it's a really good thing to do because no one else in the team realises that you're doing it. It's counterintuitive with a deteriorating high-pressure situation that's time-pressured to pause and hold the bus, and that is what's required. Special forces units talk about rally points, actually stopping the resuscitation at a lull and going round the bedside and actually finding out from everyone else what their perception of what's going on, what the problems are and what needs to be done. Resetting your cognitive appraisal of the situation and ensuring you've got a shared mental model. And then we can take that and, as a team, decide on what the action points are and, more importantly, what the priorities for action are. Your rally point is the time to cognitively offload yourself through delegation, delegation of practical tasks, of decisions, and even outsourcing decision-making to someone who's not actually in the room with you. A useful technique when things are getting really pressured is cognitive reframing. Actually getting yourself out of that situation to recalibrate your cognitive appraisal of the situation. Removing yourself from the audible and the visual stimuli of that situation. Even pretending that you've got a phone call to make and moving into an adjacent empty room. And that is highly effective in taking you out of that zone of frazzle and regaining personal composure into flow. Another technique that you can use, which is used very commonly in sport, is the concept of inner dialogue or positive self-talk. Either speaking to yourself and telling yourself that you can do it, or even Richard Levitan talks about previous mentors telling him, a voice in his ear, telling him that he's got this, that he can handle it. Again, another technique which you can do and no one knows that you're doing it. So what can we do in a zone of frazzle to move back into flow? We can control our breathing. We can self-talk. We can have a rally point, creating a shared mental model. We can actually work out what the priorities are. We can delegate. We can move outside to cognitively reframe. We can outsource, and we can use nutrition in terms of hydration, in terms of carbohydrate, and in terms of protein. So in a high-pressure situation, when you're frazzled, if you calm down, you can move back into that zone of optimal performance flow. And then finally, as an organisation, what can we do in terms of leadership, selection and culture to optimise performance? Tom Evans talked yesterday about flash teams and cardiac arrest. Tom organised a superb performance in medicine day in London 2 years ago. And one of the speakers was Gareth Davis, who's been the medical director of London's Air Ambulance for 25 years, one of the highest performing medical teams in the world. And he opened by saying that in 25 years of experience, he reckoned that 90% of the high performance ability in a team was down to selecting the right people. In his opinion, only a small proportion of people have actually got the right attitudes and the right aptitudes to perform under pressure. So to fill your team with those individuals, you need a big pool to recruit from, to select from. And a big part of high-performance teams is improving and optimising the reputation of your team and actually actively marketing it and branding it. Again, something we're not good at in medicine. High-performance teams are always trying to identify and manage marginal gains to improve performance. But again, going back to Andreas's talk, we need to have really good quality metrics that we are comparing our performance month on month, week on week, and very importantly in our retrieval subspecialty with teams doing a similar job internationally. We need to have low thresholds for people reporting things that maybe could have gone better. And DATEX is not an effective way of doing that. It's not a low threshold manner of capturing that information. So for a number of years, again, as part of the EMRS iPhone app, we are able to report incidents in under a minute, even when we're in flight and not got a 4G signal. And that lowers the threshold for reporting, and one of our consultants is responsible for investigating and actively feeding back to people to encourage more reporting. How well do we debrief as teams? Is that routine for us? And have we actually taught our teams how to debrief, and have we got a structured format for that? And is there organisational learning as well as learning from the team? A highly effective way to improve your debriefing is actually video recording of resuscitations. And for the past 4 or 5 years, EMRS, we've filmed all of our emergency anaesthetics. The paramedic films me and I film them. And when we get back, we look at that footage. And that's been very, very effective in organisational learning, but really looking at how you behave, how you come across to other people, especially in terms of non-verbal communication, something I'm not very good at. As an organisation, what culture do you have to allow learning from events to get those marginal gains? Do you have a just culture where people know that they're not going to be criticised inappropriately? Do you have a psychologically safe culture where people know that they can speak up at clinical governance meetings and they are going to be supported by their colleagues? And then finally, from a leadership perspective, how we look after people and get the most out of them. And I really like the iceberg model of the psychological contract. This is an iceberg which is divided vertically into 2 halves. On one half, what the team member can provide to the team, and then on the other half, what the team can provide to the team member. And if you work in McDonald's grilling burgers, it's pretty simple. There's 2 halves above the surface. You give them hours, and the manager gives you an hourly rate. But in high-performance teams, the organisation needs to invest in people in terms of their own personal development, needs to give them responsibility and ownership of the team. And in return, nothing to do with money, they are going to give you commitment and they're going to give you loyalty. So to finish up, if we do in emergency medicine and pre-hospital and retrieval medicine want to attain and maintain that zone of optimal performance flow, we need to realise it's all about how we manage the pressure. And we can do that in 4 ways: through proper training, through controlling the pressure with the right ergonomically planned equipment and cognitive aids, through the whole organisation with culture, leadership and selection, and we need to give our teams the tools to manage that really unpleasant stress and cognitive overload, high pressure frazzle. But as we all know in emergency medicine, we need to be light on our toes, we need to duck and dive. So even with the best systems, we need to look to performance coach Mike Tyson for final advice. Thank you.